Thank you for the invitation to give this talk. A short presentation of myself is that I'm a consultant at the pediatric department at Herlev Gentofte Hospital here in Copenhagen. I'm heading the pediatric endocrinology, and next to that, I'm also a clinical research associate professor at the Copenhagen University, and in the Danish Diabetes Academy, I'm part of a member of the Committee of Education. I have a small research group myself where we primarily are focusing at the children and adolescents with type 1 diabetes, especially focus on the pathophysiology of the remission phase and the endocrine and metabolic challenges, as well as early signs of late diabetic complications during longer type 1 diabetes duration. So today I'm going to talk a bit about the the insulin resistance, and most people, they relate insulin resistance or insulin sensitivity to obesity and type 2 diabetes. However, there are indications that insulin resistance also may have a role in type 1 diabetes, especially in the adults. It has been looked into for many years ago, but also during puberty, and especially in adolescents with metabolic decompensations and type 1 diabetes. However, the insulin resistance is not generally considered to contribute to type 1 diabetes pathophysiology. As the general population is growing bigger and bigger, that also goes for children and adolescents with type 1 diabetes, and this obesity epidemic probably doesn't do any good for type 1 diabetic patients either, and especially if you look into the fact that it has been reported several times that some type 1 diabetic populations actually have a higher BMI compared to the general population. So that's not improving the insulin sensitivity, unfortunately. As a risk of cardiovascular disease is already present in lean adolescent girls with type 1 diabetes, the extra burden from overweight might potentially harmful and affect the insulin sensitivity. So the fact that the obesity is improving, or sorry, not improving, but is increasing in number, that also affects type 1 diabetic patients and the insulin sensitivity. So the agenda for my talk today is that to discuss a bit what is insulin sensitivity and how do we measure it, and does insulin resistance exist in type 1 diabetic children and adolescents, and does it matter, and where to go from here, and what are the future challenges. So what is then insulin resistance in children? And this consensus paper 10 years back tried to give an idea of that, and it's not much different from what you see in adults, because insulin resistance here is defined as the decreased tissue response to insulin-mediated cellular action, and is the inverse of insulin sensitivity. So the term insulin resistance is generally applied and refers to the whole body reduced glucose uptake in response to physiological insulin levels and its consequence effects on glucose and insulin metabolism. And the reason that's how to define it. And the thing is that the definition is needed in order to identify how to measure it and what methods to be done in order to do so. And this systematic review a few years back tried to put all these different methods together. And from all these techniques, you can see that they depend on some kind of endogenous insulin production. You can see that this is the HOMA index, the Quickie, the HOMA2, the OGTT, etc. And all these techniques require that you have some kind of own production or endogenous production of insulin, which obviously is an issue when you are looking into type 1 diabetic patients, because they have none or very little. And the reason to make sure that you have, especially if you look into larger cohorts and want to compare them to what happens over time and compare different cohorts to each other, it is that you need to have a uniform definition of insulin resistant. It is needed to allow for such comparisons between studies and populations and to be able to follow trends in incidence and prevalence rates over time. So that makes, I think, very good sense to most. Again, the issue is what method to use. So this method was developed many years back. It's called the Hyperinsulinemic euglycemic clamp. And the idea of using this clamp is that you give insulin from an infusion pump in the end at very large amounts, and that is in order to suppress the hepatic glucose production, so that all this insulin, in order to avoid hypoglycemia, to maintain euglycemic, you need to give insulin infusion. You need to give, obviously, glucose infusion. And when you are in a steady state and these two are counteracted to each other, then you can say that the glucose infusion rate tells you something about how insulin sensitive you are. So the more insulin sensitivity you are, the more glucose you need to infuse. And you can also look by tracers, you can look into the glucose disposal rate, again telling you something about the more glucose you can dispose, the higher insulin sensitivity you have. I'll come back to this technique later, because this is obviously a very unphysiological test, because you're using very super high physiological levels of insulin. However, this has been the golden standard for many years now. If you look into assess insulin action on peripheral glucose utilization and non-esterified fatty acid suppression, both as predictors of coronary artery calcification, then this study looked into that in adults, and they compared then type 1 diabetic adults to controls, and they were fairly similar, except obviously for the differences between type 1 diabetes and controls, here being they have a higher HbA1c, as you can see here, and the fasting glucose also obviously higher, but all the other, many of the other parameters are the same, except for a bit in the cholesterol system. But especially you can see that in the type 1 diabetic patients, they have a much lower insulin sensitivity than the non-diabetic controls. And that was unfortunately associated to predict the extent of coronary artery calcification, and not related to current glycemic control. So it seems to matter in type 1 diabetic adults. If you then look into adolescents, what this study tried to show was that would it be more beneficial for the young adults if they achieved the guideline goals defined by the American Diabetes Association or the International Society for Pediatric Diabetes. So what they did was that they divided the individuals into 3 groups, on how many of the goals they fulfilled, and the goals they were to fulfill the HbA1c level goal, the BMI, blood pressure, body mass index, yeah, that's the BMI obviously, and blood pressure and the various lipids. And here you can see that the more goals they fulfilled, so the closer they are to the recommendation or recommended targets of treatment, the higher insulin sensitivity they actually had. So that was the conclusion from this, and they also find that they had better cardiopulmonary fitness along this better reach of treatment goals. Then if you want to divide the insulin resistant at an organ level, that has been tried as well, also in type 1 diabetic adolescents. And by that you look into, here they then compared 2 groups, the type 1 diabetic group of 35 individuals to 22 in the control group, with similar age range and male, female, height, etc. And again, obviously here you can see again the yeah, so they're actually very similar to each other, these two groups. And then if you look into the results from this is again the hyperinsulinemic euglycemic clamp technique done. But what you can see is that they use different grades or infusion rates of insulin, because it's believed that if you have the lower levels of insulin infusion, you can actually tell something about the adipose tissue. If you go to the high, the medium, that would be the hepatic insulin resistance or sensitivity you're looking into, and the very high concentration represents the peripheral insulin sensitivity. So this first part here is just to illustrate that comparing the controls to the type 1 diabetic patients, you can see that that they actually obtained the different insulin levels by the infusion rates. If you then look into the endogenous glucose production, again, as I said from the technique slide, you know that insulin will suppress glucose production from the liver. And here you can see that the 16 state of insulin infusion clearly suppress the glucose production from the liver better in controls than in type 1 diabetic patients, again indicating that the insulin sensitivity is reduced in the type 1 diabetic patients within the liver. And again, if you compare the predicted endogenous glucose production between type 1 diabetic patients to obese, you can see that even actually the obese have a better sensitivity in the liver for insulin than the type 1 diabetic patients. And again, not surprisingly, looking to the high rate infusion of insulin, telling you something about the peripheral insulin sensitivity, you can see that the controls had a much higher insulin sensitivity compared to the type 1 diabetic patients. So they concluded that youth with type 1 diabetes have a profound multi-organ insulin resistance, including the adipose, the hepatic, and the muscle tissue, without featuring or any features of metabolic syndrome. And it recurs regardless of obesity. So it's not related to obesity by itself, but it might be a part of the type 1 diabetes itself. And again, using the same technique, comparing in another study what happens, this sensitivity in controls, and here the type 1 diabetes patients is at the same level of the obese, although the type 2 diabetes patients actually have the lowest insulin sensitivity, which is not surprising, but still identified in the study. So this study here tries to look into, does it really matter? Does it matter if you have a higher or lower insulin sensitivity or resistance? And this study here, again, 10 years back, identified that there was an association between the insulin sensitivity to a more atherogenic lipid profile. So the lower insulin sensitivity, the worse lipid profile you had, and that was actually across lifespan to people, or people with type 1 diabetes, even demonstrated in the youngest years, but also later on in life. So it's not something that comes or will change or disappear later on. In this study, they hypothesized that the cardiopulmonary fitness was reduced in type 1 diabetic youth in association with insulin resistance and cardiovascular dysfunction. And so they unfortunately were actually able to demonstrate that youth with high insulin resistance had impaired exercise capacity and cardiovascular dysfunction. And this phenotypic way it looked was different to those with type 2 diabetes. Now, can you do something about it then? So this fairly recent study published last year tried to see, can you do anything about the insulin sensitivity by using a very old drug? As you know, the Metformin has has shown for many years to improve insulin sensitivity, especially within the liver, but also peripheral. And this is actually what this study showed. They treated for, I think it was 3 months with metformin, and they identified here, if you did the, this is the difference in, or the change in the parameters for those having placebo and those having metformin. And you can see here that the placebo group versus the metformin group were significant at the glucose infusion rate after 3 months therapy with metformin. And you can also see that goes in even more distinct difference if you look at the free fat mass. And again, that was the infusion rate, but again, looking at the disappearance rates, the difference, although here not significant, but seems to be clear. And the glucose metabolic clearance rate was significant between the two. So hopefully the metformin seems to work. Also an indication of that if you reduce the sensitivity, you get better metabolic outcome. These studies, though, didn't show any difference in HbA1c or free fat mass, and there was a minimal weight reduction. But it seems to improve whole body insulin sensitivity. Now, the issue of using this hyperinsulinemic euglycemic clamp is that it's very time-consuming and fairly difficult to do, and it takes a lot of time. And most patients do not like to be part of such studies. So this study here tried to make an estimate or a surrogate marker for the insulin sensitivity based on this hyperinsulinemic euglycemic clamp. So they made an estimated insulin sensitivity, and they found that it was that the markers that you need to measure in order to get this estimate is the waist and the level of triglycerides, the adiponectin, the diastolic blood pressure, total daily dose of insulin, and fasting glucose and HbA1c. And if you have those 6 to 7 measures, then you will be able to make a fairly good estimate of insulin sensitivity based on the clamp technique, which obviously is much easier to do it in this way. So that's an instrument that might come in handy. And again, using this instrument, this group from Australia, they looked into what can the metformin do for the vascular function in children with type 1 diabetes. And that was a 12-month randomized controlled trial. And I know this next one here is very busy, but you can see over here that these outcome parameters, the FMD, that is the flow-mediated dilatation. So all these measures are measures of vascular function, and they are non-invasive, which is a good thing when you are, well, in general, but especially when you are a child and children and adolescents. They don't want to be part of needle shows too much. So basically, you can see here that there was a positive effect from these measures to the metformin treatment, and you can also see there was a slight reduction in HbA1c from 8 point. No, it didn't drop as much. There was it was positive, but it was not clinically. It was not very massive, but there was a direction the correct way, in the sense that you saw improved metabolic control, and you could also see that the amount of insulin was reduced over time, and you saw that the markers for vascular dysfunction improved a bit, which seems to be very positive in probably in the long run. So they summarized to say that they could demonstrate benefits of metformin on vascular function, HbA1c, insulin dose, and as the estimated insulin sensitivity as well over 12 months in children with type 1 diabetes. It has to be said, though, that these children had a weight above average, and there was a good safety profile, and they think you should move on with more studies in that regards in order to improve outcome for late diabetic complications in the long run. And in the end, I'll just talk a bit about some of the studies we have done ourselves and the relations to insulin sensitivity. We are looking into another organ that might have a dual effect on the insulin sensitivity, which I'll come back to a bit later. However, so that is the bone system, the skeleton. And first we did a study where we, in the patients that we follow here at the Harlow University Hospital, we could not demonstrate that they had reduced mineral bone density. So, which is unlike in adults with type 1 diabetes, where you see that the bone density seems to be decreased, but in this cohort, it was not decreased. It was identical to normal controls. And you also saw that the HbA1c was negatively associated with the bone mineral density, indicating that the higher HbA1c, the lower bone mineral density we saw, which may be one of the reasons that over time we see in adults that the bone mineral density will go down because they have not optimal HbA1c levels. So we then looked into the bone turnover markers in the same children with the aim to see whether the bone formation markers, the osteocalcin and the PIMP, versus the resorption marker, CTX, to see if that was to investigate those levels in children with type 1 diabetes, and to see if there were any associations to metabolic outcome or bone mineral density itself. And from this slide here, you can see that all the bone formation markers were at a lower set score, meaning that they on average was lower than controls. And especially the CTX one is interesting because that was the only one that was associated to the HbA1c, indicating that the higher CTX set score you had, the lower HbA1c. And as you remember, the CTX score, the CTX marker is indicating bone decrease in bone mineral density. And this effect was independent of age, type 1 diabetes duration, gender, total daily dose, and fasting C-peptide. So maybe the CTX has something to do with insulin sensitivity, and we hypothesize that the bone seems to decrease their bone mineral density in order to improve sensitivity and thereby reducing the HbA1c. So the bones are trying to kind of do their best in order to help the insulin sensitivity, but the price they pay is that you get a reduced bone mineral density. If we then look into the bone markers during the remission phase, and not for those previously who had long-time diabetes, again, look into what happens with the bone turnover markers during the remission phase. And we define the remission phase either as you have a stimulated C-peptide above 300 picomoles per liter, or we use the insulin dose adjusted HbA1c, which is another measure for the remission phase. And here you can see again in the remission phase that the osteocalcin and the PIMP are lower than normal at 3 visits. That is around or shortly after onset of diabetes. This is half plus 6 months and another plus 12 months. So this is over a year. You can see the fairly stable, whereas the CTX was actually higher than average or than controls. And then if you looked over what happens over time and see what do the bone turnover markers do, or are they associated to the decrease in C-peptide, which is a marker of endogenous insulin production, we could see no association between bone turnover markers and the loss of C-peptide. However, if we instead use the HbA1c, and the HbA1c, as you can see, declines over declines over time, indicating that at some point here the remission phase is over. You could see that the higher CTX level you had, the slower or the longer time you seem to stay in remission compared to those that had a very low CTX level, which they had a steeper decline in the HbA1c and having a shorter remission phase. Again, indicating that the bones seems to affect the remission phase in some way. Again, the higher CTX, the longer remission phase, and probably due to a better insulin sensitivity because the CTX was not associated to the decline in C-peptides, so the endogenous insulin production. So this is the hypothesis that we work from. And very lately, we have looked into the same population again and looked and divided them in those not in remission versus those in remission, and then split each group in those that produce or have endogenous insulin production and those who have not. If you're less than 300, it may not be much, and it has a very little role in the clinic. And here you can see the definition of the HbA1c that takes the average of, or takes the HbA1c into account as well as the insulin dose that you take from yourself or from exogenous insulin. And then the data here again suggests the 4 groups. This group is fairly small. Only 5 patients were in this one out of 80 in total. And the other parameters we looked was the age, the BMI, the HbA1c, and then the C-peptide and the estimated insulin sensitivity score, which is the calculated one. And then comparing those not in remission, not obviously this group seems to be fair enough, because if you're not in remission, you do not produce insulin, and you can see this group produced less insulin than the other group. It is though a bit weird, or you need to think about this group because they actually do produce a lot of insulin, but compared to the other group here that do the same, these are in remission, these are not. And the difference between the 2 groups is that these in remission seems to be leaner, they have a lower BMI, but they do produce the same amount of insulin, these 2 groups. They are comparable. It's not because these do much less, actually they seem to produce a bit more than these one. But these are more lean, and again here you can see these group being lean, they also have a higher insulin sensitivity, making that this amount of insulin seems to be sufficient for those to enter the remission phase, whereas those over here, despite the fact they produce a lot of insulin, they have insulin resistance, and hence they end up not being in remission despite the insulin production. And it seems to be this group, group 4, these are the group that are in remission, but they produce very little insulin. You can see this insulin production, especially after 12 months, is very short. However, they have the highest insulin sensitivity, which might be the reason that this group is still in remission despite their low endogenous insulin production themselves. So we find it fair to say that insulin sensitivity do play a role in the remission phase, but also in the longer term of type 1 diabetes, and the bone seems to be somehow involved in that. So to summarize, insulin resistant in type 1 diabetes in children, yes, it surely is a phenomenon, and it's not compared to normal children, and it's dependent, and the effect of insulin resistance is independent of the obesity state. It's more pronounced if you're obese, but it still happens if you are lean, and is also to be independent of metabolic control. Again, the higher HbA1c, the higher insulin resistance you have. Does it matter? Yes, it does matter, because it associates to cardiovascular risk factors, and the good thing is it's modifiable. Metformin has been shown as one, but it should also be the negative side is that it might be that the bones they try to compensate, and by their compensation process, they seem to degrade the bone tissue. So where to go and what are the future challenges? One of the challenges is that we need to establish more physiological methods to assess the insulin resistance or sensitivity. As I said, the hyperinsulinemic euglycemic clamp is not very physiological because it's massive amounts of insulin that you need to use. So we are in the process of seeing if you can do mixed meal tolerance test instead. But here the challenge is that what do we do about the lagging endogenous insulin production for the patients themselves? How much should we give them insulin, and will that affect, which it obviously will, the outcome? And then we need to find better surrogate markers from these studies. And again, we need to understand better associations to the phenotypic traits, what happens to the cardiovascular risk, what happens to the bones, and again, how do we modify the insulin resistance? Should we use other add-on therapy than the metformin that has been used so far, or should we use any other kind of ways to modify the insulin resistance that has nothing to do with medications? Non-pharmacological treatments, what will happen and what will do and what is effective. So with that, I will say thank you to you, and I'm happy to take any questions that you might have.
Maria, do you have a question for Jesper?
Yes, I have. Hi, Jesper, and thank you for the very nice presentation. So metformin improves both peripheral insulin sensitivity and vascular function. Is it known if these two effects are mediated via the same or independent pathways?
Yeah, that's a very good question. To my knowledge, no, it's not known whether it's the same, and it's not known either if the effect on the hepatic insulin sensitivity is the same as in the peripheral, in the muscle. But that's an issue that needs to be discussed and to figure it further out, and also to see if there are any other mechanisms or pathways that could be more selective if you want to go into that.
Thank you. And there's also a question from Caroline.
Yes, hi Jesper. Thank you for a nice presentation.
Thank you.
We were wondering in our group how you can compare control subjects with type 1 diabetes individuals with regard to insulin resistance, because if you are taking into account the fact that the patients are receiving exogenous insulin, which is not as potent and administered differently than the endogenous control subjects, how you actually can state that it's insulin resistance and not has something to do with the insulin medication you're providing.
It's true that when you when you take insulin, you give it in a different way than because it's given primarily or only in the periphery and not in the system of the portal, the hepatic portal system where it's supposed to be. But the idea with the hyperinsulinemic euglycemic clamp is that you give a lot of insulin, and that the insulin at those amounts are so much larger than that you see normally. So in that regard, the endogenous insulin production within the control subject is probably fairly suppressed, so that the most of the action you see is from the very physiological levels of insulin that you give within the test setup, and it's the effect of that insulin that you are measuring, and that should be the same, and thereby you'll be able to compare controls to any kind of subjects that you like to compare.
And I can't see that. There's another one from Sasha.
Yeah, sorry, I was wondering if you could just elaborate on that. So I was wondering, why somatostatin was not administered during the clamp?
That's that's true. It has been used as well, that you use somatostatin in order to block the endogenous insulin production. But as I said, that's more likely to be done if you are working closer to normal physiology, and that is the reason that it's definitely needed to see if we can do some better testing within type 1 diabetic patients with the mixed meal tolerance test and using glucose tracers in order to see or to measure the disappearance rates into different tissues. But when you use this very high insulin level, then the effect of the endogenous insulin production is close to minimal. And anyway, that's the rationale for doing it. But it's a good point. If you want to go to have a closer look at normal physiology, then somatostatin is one way to suppress insulin production.
Thank you.
Okay, yeah, thank you very much. I think that was the last question. Thank you very much, Jesper, for your presentation.
Thank you so much. You're welcome.